and they're not even coming close to going through all of it. I looked at the initial stuff with him, and it's definitely cancer. He thinks it's probably more aggressive than less aggressive. A lot of it's dead tissue that has probably outgrew its blood supply. He thinks it might be urothelial cell, basic bladder cancer, but it said there's probably some sarcomatoid features and some other stuff. It's not garden variety anything. He said he still can't rule out that it's coming from something else, gynecologic, things like that. Based on your exam under anesthesia and the CT, I suspect it still originated in the bladder, but all that's yet to be determined. They're going to send out for some special stains, and so it may be a little while before we know. You don't see oncology ever, have you? You never seen any of the oncologists, have you? All right.
This is what's hard for me to process.
Mm-hmm.
I've had colonoscopies and cataract surgery. That's it.
So I'd like you to get to see oncology even probably about the time we get the pathology back. So for most of the time, if it's pure urothelial cell carcinoma, it's based on whether it goes into the wall or not. And I don't honestly know if we got into the wall or not. I know I did in a few spots, but will they be able to find it in this massive tissue, one little spot? I don't know if they will or not. But the guidelines for some of the atypical variants of bladder cancer sometimes say treat it more aggressively. And so one of those things would be possibly chemotherapy, or talking more about taking the bladder out and just getting rid of everything. And so I'd rather get you in to see them sooner than later because of that. Now, there may be a role to go back in about a month and try to clear out the rest of it, get further into the bladder wall and confirm whether it's muscle invasive or not. I don't know if what we did before will tell us that or not. If they see muscle and there's tumor in it, then that tells us we're in, muscle invasive or stage 2. If it just says, hey, there's cancer and we can't tell, then we would need to do that, unless oncology says, no, with what we've seen here, I don't think it's worthwhile to ever try bladder preservation. We need to be more aggressive. And it's the guidelines aren't particularly clear on that. They said, if it does have these variants, consider treating it more aggressively. And typically, if it's high grade, but not into muscle bladder wall, we try to preserve the bladder, but once it gets in, we take out the bladder as kind of the standard, although there are chemotherapy and radiation options. But some people, even with high-grade non-muscle invasive or recurrent, taking out the bladder becomes the right answer. And so I'd kind of like to get things going a little quicker, especially based on your history. This all just kind of coming out of the blue fairly quickly. Mm-hmm. I don't know how long it's been there, but I'd rather not kind of just keep delaying things longer and longer. And so I'd probably do is get you up to talk to one of the oncologists at KU, or the oncologist here, but one of the urology oncologists at KU who does cystectomies, at least get you plugged in with them. So if that does become the answer, then, it doesn't delay things further.
Okay.
How long does it take? Because when we were working with our son, mm-hmm. It was like very long lead times dealing with KU.
We'll start the process now again early on. If it does come back as atypical and says, like we think, or something weird that we need to move quicker, then I can call one and say, hey, here's what we got going. If I just call and say, hey, I've got this lady with a bladder mass, we don't know anything else, they're gonna be like, well, call me when you know some more. But if we say, hey, this really needs to be speeded up a little bit, then I can try to talk to them, see if they can kind of get you in quicker. And so I think it's worthwhile to get you in to see oncology, ASAP. Hopefully by the time you get in, we'll have more pathology, know a little bit more, and they can kind of start getting things moving.
When you say in oncology, here or there?
You could do either. I would start here. They work with the people at KU quite a bit. We don't take out the bladder anymore here, and so for oncology or for urology, I'd want you to get up to KU for that.
So one of the things that we really want to do is to preserve the bladder if possible. So Can you talk a little bit about the pros and cons of that?
Not well in this situation, because most of this data is based on people with just straight urothelial cell carcinoma, and I don't know if that's what we're dealing with. And based on the pathologists in my discussion, my guess is it's not going to be that, because they only saw one little spot so far that looked like typical bladder cancer. Everything else just looked different. And so I can tell you general things for people with stereotypical bladder cancer, but I don't know if you fit in that.
Right.
And I don't know if they would be relevant to you, or, you know, sometimes different cell types behave much differently, and to try to paint you a picture for somebody with the average bladder cancer versus you may be completely wrong.
So when will we be able to have that discussion?
So it's gonna really depend on once we get all the pathology back. I was hoping they'd be say, okay, here it is, but they, he said there's an awful lot dead, and usually we give them a little pile about that big, and I give them about 10 piles that big on you, and I can't tell them, hey, here's the part you really need to look at, because it all gets mixed in. And so it's a little bit like finding a needle in a haystack, or a small haystack, trying to find that spot. Is this normal bladder that we got into, and is there a tumor there? And a whole bunch of the different cells look variants of, he said could be colon, could be gyne, could be bladder, could be, he's just not sure. He says it's cancer, it looks aggressive, but that's really all he could tell me.
Okay, so that's all we really know right now.
Yeah, it definitely is a cancer, but what subtype, he thinks probably bladder, because he saw one little frond in there that looked like a typical papillary part. But he said, as seemed apparent, it's not just all straightforward bladder cancer. And so it's, again,
Say that again.
so cancers are, we look at different types. Lung cancer has a certain type of cancer cell, colon cancer, different types called prostate cancer. They originate from a different cell type. So most bladder cancer starts as urothelial cell carcinoma, or urothelial cells, which are the lining of the bladder. And that's typically what we see. In different parts of the world, they see more squamous cell. And he actually, I think, did see a little bit of squamous differentiation as well. But cancer cells can, do whatever they want to. And so part of it is, if this said, hey, this is all from the colon, then one, we know that that's metastatic colon cancer because it's gone to the bladder, and then there's a primary somewhere else. If it said, hey, this is from other etiology than bladder, we have to look at where did this come from, because we may see this, but there's somewhere else that sent it there. If it's primarily bladder, then we can say, hey, it looks like it started here, and then it developed and changed however it wanted to. My general feeling is it started in the bladder, whatever it is. Just from, like I said, your exam, everything felt nice and mobile and loose. Your CT scan didn't show a whole bunch of stuff invading into the bladder. It looked like it was starting there, though there was that little weird curve on the left, which I'm still not sure what to make of that. And so that's kind of where we're at for that. This Friday, I want to see how your kidney looks, to see if it is starting to drain, if I got enough for section to drain it. If not, then we've got to kind of see what the next plan is. I suspect that you're getting some drainage from it because that pyridium stayed in your bladder for a long time. And I suspect that it was from the left kidney just draining out slowly. But depending on what the next step is and how your kidney's draining, then we've got to decide, do we leave it alone, or do we try to drain it internally, or do we put a tube in the back to keep it as functional as we can? And that's the other thing we have to kind of look at. So there's